we'll start. Yeah, the technical team, can we go ahead with the presentation?
Yes, sir, you can
Go
start.
for countdown.
You can start, sir. We are live.
Yeah, thank you. Thank you. So good evening and welcome you all for this API-ICP postgraduate virtual training program. From this week onwards, we are going to have the faculties from and postgraduates from the Department of Medicine, PSG Institute of Medical Science and Research, Coimbatore, along with the specialty department, depends on the type of problems you're going to discuss. And this week we're going to start with Department of Neurology and Medicine. We have with us the faculties from the Department of Medicine, Dr. Dinesh Narasimhan, the Professor of Medicine and Unit Chief. Welcome, Dr. Dinesh, for this evening, and thank you for accepting our invitation.
Thank you.
And we have with us the Professor and Head of the Department of Neurology, Dr. Balakrishnan, from PSG Institute of Medical Science. Dr. Balakrishnan, thank you for accepting the invitation and being there as a faculty today.
Thank you, Saranand.
And we have with us Dr. Sanjo, the consultant neurologist from PSG Institute of Medical Science and Super Specialty Hospital. Dr. Sanjo, thank you for being today as the faculty for the neurology case discussion. And we have with us the Kaushik Ram, the postgraduate, to discuss about this presentation. I request Dr. Kaushik Ram and the faculty to take over further proceedings of this today's presentation, a case of ataxia, how to approach. Over to faculties and the postgraduate. Thank you.
Good evening, sir.
We're going to start presenting.
Yes, sir. Yes, good evening, all. I am Dr. Kaushik Ram, a final year postgraduate, Department of General Medicine, PSG IMSR, Coimbatore. Shall I start my case presentation, sir?
Yeah, go ahead.
Yes, yes, my patient, XY is that.
Dr. Balakrishnan and Sanjo and Dinesh can ask him to present, interrupt then and there whatever you want to discuss from the historical aspect as well as science-wise and differentials and investigations in this stepwise manner. It's always useful for the postgraduates listening to that. Thank you.
Sure, Dr. Yeah, you can start, Dr. Kaushik, you can start.
Yes, sir. 49-year-old female patient, XYZ, who is a graduate, currently unemployed for 2 years, who was previously working as high school teacher for more than 20 years, from Kotagiri, a right-handed individual, informant is self and her husband, and it's reliable. And she came with the chief complaints of unsteadiness while walking for 4 years, difficulty in using the upper limbs for 3 years, difficulty in using lower limbs for 2 years, and slurring of speech for 2 years. History of presenting illness. Patient was apparently normal 4 years ago. Thereafter, patient developed unsteadiness while walking, which was insidious in onset, gradually progressive in nature, and it was associated with swaying to both the sides. And the history of unsteadiness while sitting in the chair without the backrest and was not able to sit in the back of two-wheeler. History of walking with the legs wide apart, just noticed by the family members, and history of difficulty while walking fast with a tendency to fall.
Actually, Kaushik,
course of time. Yes, sir.
Kaushik?
Yes, sir.
No. Let's go to the first slide. I think this unsteadiness, I think, okay. Okay, next slide, yeah.
Yes, sir. The patient was, in the course of time, in the 2 years, unsteadiness aggravated even while closing the eyes, during the night times, while getting up for restroom, and in the dark, such a way that she doesn't switch off the lights at home. Unsteadiness was associated with fall backwards 3 times. Thereafter, she stands up with help, not associated with any head trauma, loss of consciousness, altered sensorium, involuntary movements. No history of any nausea, vomiting, ear pain, discharge, hard of hearing, and tinnitus. Patient had difficulty in using both upper limbs for 3 years in the form of scribbling while writing in the blackboard. Initially, patient managed to write. Later, it was progressive and patient not able to write properly and had to quit her job. History of clumsiness while reaching the objects, holding of glasses and utensils. History of spillage of water and food while attempting to bring close to the mouth while eating, but managed to eat. No history of difficulty in combing the hair. No history of difficulty in reaching objects above the head. No history of any dysphagia to solids or liquids. No history of any cough during feeding. No history of any hoarseness of voice or nasal speech. History of tremulousness, which was absent at rest, but more on attempting to do some work. Patient had difficulty in using both lower limbs. With the history of difficulty in getting up from the chair from squatting posture, after using restroom. Initially, patient was able to climb stairs. Thereafter, patient had difficulty in climbing upstairs and downstairs. Patient attributes such a way that she avoids using stairs due to increased swaying. No history of difficulty in wearing and gripping chappals, insinuating foot into and out of the chappals, and history of unintentional weight loss of about 11 kgs in the last 3 years. No history of difficulty in rolling over the bed or getting up from the bed, lifting the head from the pillows. No history of any stiffness, weakness, flailness of the limbs. No history of any abnormal shortening of the limbs, muscle ache, twitches or tenderness. No history of any diurnal variation of difficulty in using upper limbs or lower limbs. No history of breathing difficulty. Thereafter, in the course of time, patient developed slurring of speech in the last 2 years in such a way that the flow of words are affected and had multiple pauses in between each syllables and expressed it with greater effort. However, she had no difficulty in understanding the spoken words, repeating the words, or naming objects. She was able to feel clothes over the body. She was able to feel hot and cold water while bathing. No history of numbness or pins and needle sensation in the limbs. No history of walking in cotton wool sensation. No history of neck pain, back pain, or band-like sensations. No history of any shock-like sensation passing over the spine while bending the neck. And patient is able to appreciate smell.
No. I think now you're going to the cranial history.
Yes, sir.
Next one. Okay. What are generally the causes of unsteadiness while walking? What are the three major conditions? Three
Sir,
major causes. Yeah.
Sir, it may be cerebellar cause, sir.
Okay.
Our posterior column pathway defects.
No. Usually you have to say the cerebellar arteries connections. Okay.
Okay, sir.
So mainly it's cerebellar ataxia.
Okay, sir.
So cerebellar ataxia maybe because of the cerebellar ataxia, maybe because of the cerebellum or its connections involved. So what are the connections?
So like superior cerebral peduncle, middle cerebral peduncle, and inferior cerebellar peduncle, sir.
And there are a lot of tracts also.
Yes, sir.
Frontal cerebellar tracts. Okay.
Yes, sir.
So which carries fibers from the frontal cortex to the cerebellum. Okay.
Yes, sir.
So and what are the other cause of ataxia?
So like sensory ataxia.
What is
which
very
involves-
classical of cerebellar ataxia? If you have these findings, definitely you will say this is classical cerebellar ataxia.
Sir, patient may have dysarthria, sir, nystagmus,
Okay.
sir.
Okay, these are the two characteristic features of typical cerebellar involvement. Okay.
Yes, sir.
And what are the other cause of ataxia? Other
Sir,
common
maybe due
causes?
to maybe vestibular causes, sir.
Okay.
And posterior column
What is the
pathway.
most common condition can cause acute maybe ataxia because of vestibular involvement?
Sir, any vestibular neuritis, sir?
Okay, vestibular neuritis. Okay. So, do you have a dysarthria and vestibular ataxia?
Sir, sorry, sir.
Do you have dysarthria and vestibular ataxia?
No, sir, no, sir.
So how do you so if it is unilateral vestibulopathy, so how do you differentiate clinically cerebellar or vestibular ataxia?
Sir, vestibular ataxia patient may have difficulty in balance and
Usually it will be unilateral.
tinnitus, nausea, vomiting, sir.
No. Usually it will be unilateral ataxia
Okay, sir.
unless there is a bilateral vestibulopathy. Okay.
Okay, sir.
So bilateral vestibular involvement. Okay.
Yes, sir.
So usually usually they have a different tendency to sway to only one side. Okay.
Okay, sir.
So like if the right vestibular superior vestibular nerve is involved, they'll have typical swaying to the right side. Okay.
Yes, sir.
So but if you have bilateral vestibulopathy, they have maybe swaying to either side. Okay. So
Yes,
that we call it as disequilibrium. Okay.
Yes, sir.
We don't call it as ataxia, bilateral vestibulopathy. Okay.
Yes, sir.
And usually, typically, we have different type of nystagmus in vestibular vestibular lesions. Typically, horizontal nystagmus with a rotatory component. Unilateral nystagmus. Okay.
Okay, sir.
But in cerebellum, you'll have bilateral nystagmus. You can have horizontal or vertical or rotatory. You can have any type of nystagmus in cerebellum.
Okay, sir.
So as I told, they can have other conditions like tinnitus, hard of hearing, if it is there is a labyrinthine involvement.
Okay, sir.
Okay. So what are the other major cause of ataxia?
Sir, like sensory ataxia, sir. Then
Okay.
psychogenic ataxia, sir. Ataxia, abasia.
Okay. Okay, that's okay. How do you clinically differentiate sensory ataxia?
Sir, in sensory ataxia, sir, there will be sir, the reflexes will be absent, sir. Then there will be a worsening of symptoms in the dark, sir. and which
Okay.
improves on visual clues, sir.
Okay. In the dark or eye closure?
With eyes closed, sensory ataxia will be worsening, sir.
Yeah. Okay. So what are the lesions can cause sensory ataxia?
Sir, posterior column pathway, sir. Dorsal column
Okay.
pathway. Then peripheral nerves.
Oh, no. Yeah. First thing you have to say is the large fiber neuropathy.
Okay, sir. Large fiber neuropathy, sir. Then dorsal
Okay,
root
then.
ganglia
Yeah, dorsal neuronopathy. Yeah.
and dorsal column pathway, sir.
Dorsal column. Okay. So, okay, these are the three major causes of ataxia in any patient. So, whenever you have a patient with the ataxia,
Yes, sir.
so always you have to take history
Yes,
in
sir.
the way that whether you are able to fix the compliance into any one of these systems.
Okay,
So, whether
sir.
it's a cerebellar or its connections, or it's vestibular ataxia, or it's a sensory ataxia. Okay,
Yes, sir.
so this is how we usually generally approach. And here, then there is a different way of approach, like acute, subacute, and chronic.
Okay, sir.
Okay, and unilateral or bilateral, like that. Okay, you have different kinds of approach to any ataxic disorders. Okay,
Okay, sir.
okay. So this is how we approach. Okay, next. Okay.
Now, I just
Okay.
have a question, Dr. Kaushik.
Yes, sir.
You said insidious onset.
Yes, sir.
So let's go back to some very basic questions.
Yes, sir.
What are the different etiologies or categories of etiologies in nervous system relating to onset? So how would different categories of neurological disease present based on onset? I mean, which would have acute onset, something like that?
We will say for cerebrovascular diseases, sir.
Okay, what would be the onset?
Sir, depending upon the embolic stroke or thromboembolic stroke or catastrophic stroke, sir, it depends upon the timing, sir, like acute event, wake up stroke and everything, sir.
Right, so you could have an acute onset. Then what are the, so one is vascular. What are the other etiologies of the nervous system?
Sir, cerebellar can have cerebellar disorders can also have
We're
acute.
not talking about cerebellar. I'm just asking you, one you have vascular, which is pertaining to blood vessels, right? What is the other kind of etiology you can have in nervous system?
Sir, and meningitis also we can say, sir.
Okay, okay. Most
Yeah,
common
next.
conditions? Yeah.
Meningitis, sir. Acute, subacute, chronic, sir.
Yeah, so that's
Oh.
infectious.
Yeah, infections.
Infectious. What is number 3?
Sir, in
Yeah,
The
so
demyelinating disorders can present like a typically a stroke.
okay, sir.
Okay.
Yes, sir.
So acute onset. Okay. So sometimes when we have a patient, when we think it is a stroke, when you do an MRI, there will be a demyelination. Okay.
Yes, sir.
So stroke and demyelination will have a more or less similar clinical presence. Acute onset, static for some time, then they start improving. This is most typically fitting into vascular or demyelination. Okay.
Yes, sir.
The demyelination.
demyelination. What are the other etiologies of the nervous system? See, remember this vitamins D, vascular, infectious. T stands for trauma.
Trauma, sir.
A stands for?
Autoimmune, sir.
Yes, autoimmune. So what would be an autoimmune condition affecting the nervous system? SLE, myasthenia gravis.
Okay, sir.
Right? And M stands for?
Neoplasia.
Metabolic.
Metabolic, yes, sir.
What are the metabolic diseases affecting the nervous system?
Sir, like hypoglycemia, hyperglycemia, hyponatremia, hypernatremia.
Exactly, your electrolyte imbalances and your organ failures like uremia or liver failure, renal failure, etc.
Yes, sir.
So VITAM. I stands for, another I stands for?
Infection and inflammation, sir.
Yeah, we already finished infection. VI, this idiopathic or iatrogenic.
Okay, sir.
Okay. VITAM. N stands for?
Neoplasia, sir.
Neoplasia. So what are the classical categorization of central nervous system neoplasia?
Sir, pardon, sir?
How do you classify central nervous system tumors broadly?
Sir, slow growing, fast growing, sir.
Primary CNS tumors and metastatic CNS tumors.
Okay, sir.
Okay, so VITAMIN. S stands for? Seizures or PSY, psychiatric.
Okay, sir.
And D stands for? Degenerative.
Toxins, sir. Toxins,
Degenerative.
D,
Like
okay.
Alzheimer's, Parkinsonism, motor neuron disease, and so on.
Okay, sir.
So vascular will have what onset?
Sir, it may be hyperacute, acute, and
Yes. Yes. Infectious will have.
acute, subacute, and chronic, sir.
Yes. Traumatic will be.
Acute and
Yeah. Depends on the type of injury, subarachnoid hemorrhage, bleed, fracture, whatever. Metabolic will be.
metabolic.
It could be acute or chronic depending on the presentation.
Okay, sir.
Autoimmune will be.
Sir,
Autoimmune. What is the nature of presentation?
acute and chronic, sir.
It can be either one, right? Neoplastic.
The slow growing or fast growing, sir.
Yeah, it could be over weeks, days to weeks, or weeks to months.
Okay, sir.
And degenerative.
Chronic, sir, mostly.
It's going to be months to years.
Yes, sir.
Months to years. So,
Yes,
so
sir.
the onset will help us to think about how to categorize the disease.
So,
Yes.
okay, here there is a history like 4 years. Okay.
Yes, sir.
So, what do you think?
Sir,
Something chronic. Okay. Something
Yes, sir,
chronic.
chronic.
Something chronic. Okay.
Chronic, sir. It's months to years.
And there's one thing which I noticed in the history. Actually, whenever the patient develops ataxia,
Yes, sir.
usually the lower limbs, usually the patient notices the symptoms and lower limbs earlier than the upper limbs. Okay.
Okay, sir.
So usually, but here this patient has just go to the first slide.
First slide, sir.
Yeah. No, the previous one.
That's the first slide. Yes, sir.
No, here there is like you are saying this upper limbs are first involved than the lower limbs. Okay.
Yes, sir.
So actually, whenever you see, you said that this lower limbs, the unsteadiness while walking is 4 years.
Yes, sir.
But you said this second is coming to the upper limbs, then again lower limbs.
Yes, sir.
So when you say the symptoms of lower limbs are like in 4 years,
Okay, sir.
so I feel this lower limb involvement also will be like more or less same time, or maybe coming after like 3 years. Maybe patient may not be able to remember exactly the history.
Okay, sir.
Because you understand what I'm saying. So whenever you say there is a ataxia of gait, this lower limbs, okay,
Yes, sir.
then the second symptoms will be like lower limb involvement always comes the first, second, third is upper limbs, then the speech disturbance. Okay, so
Yes,
this
sir.
is like an order. Okay,
Okay, sir.
but here there is some maybe patients not able to say clearly the proper history. That's why I think because in the 4 years I think they may not able to remember exactly which has come first, which has come second. Okay.
Okay, sir.
And okay, one more thing. Why this patient has noticed this upper limbs involvement as earlier than the lower limbs? There's any clue in the profession?
Yes, sir. Because patient is a teacher, sir. So
Yeah,
she
okay. So
usually writes in the blackboard, but she noticed to have scribbling and the handwriting is altered, sir.
so sometimes all the things will start simultaneously, like speech and swaying while walking and difficulty in usually the terms like when you are presenting a case of ataxia,
Yes, sir.
the meaning of difficulty in using upper limbs and lower limbs usually indicates a pulmonary tract involvement also. No, maybe ataxic disorders,
Yes, sir.
but the meaning of like difficulty in using, usually we put it for like a pulmonary involvement, but sometimes maybe ataxic disorders also. Maybe I
Okay.
think the phrasing will be a little more better. Okay, these two things. Okay, the next slide.
Now I have one more question. Now,
Yeah.
if you assume this is a cerebellar disorder,
Yes, sir.
which part of the cerebellum do you think could be involved? So, how do you broadly classify the parts of the cerebellum?
So cerebellum can be classified anatomically, sir, and also
Yeah.
phylogenetically and functionally, sir.
Yes, anatomically, how do you classify it?
Sir, by primary and secondary fissures, it is divided into anterior lobe, posterior lobe, and flocculonodular lobe, sir.
Yeah. So in this kind of a history, do you think it is the inferior lobe, posterior lobe, or the anterior lobe which is involved?
So predominantly anterior lobe, sir.
Okay. So what does the inferior lobe deal with?
Sir, mainly balance and equilibrium, sir.
Yeah. So you could expect balance and equilibrium, and what does the anterior lobe deal with?
Sir, what is this, sir?
Anterior lobe.
Sir, anterior lobe mainly for gait ataxia, sir. Predominantly gait ataxia, sir, and truncal ataxia.
Yeah, so there's one part of the cerebellum which connects with the vestibular nucleus. There's another
sir.
part of the cerebellum which connects with the cerebral cortex,
Yes, sir.
which is responsible for initiation and maintenance of movement.
Yes, sir.
And you have another part of the cerebellum dealing with balance.
Yes, sir.
So according to you, if there's a cerebellar lesion, it could be the...
So initially it is due to anterior lobe lesion, sir. Initially, maybe
Okay.
anterior lobe is involved first, sir.
Okay, is there anything in your history to differentiate between a sensory ataxia and a cerebellar ataxia in your history?
Sir, patient,
So,
sir, patient is,
would you say it's predominantly cerebellar ataxia, sensory ataxia, both, or would you argue in with reference to any one?
sir, at this point of time, I can say it could be both cerebellar and with this history, sir, the unsteadiness, and the patient has more symptoms on closing her eyes and on dark, sir. So I would like to point towards cerebellum and sensory, predominantly sensory, sir, as of now.
Okay, if it is sensory, would you think so upper limb and lower limb, you feel the posterior column long fibers are involved in both the upper limb as well as the lower limb, or only the lower limb?
Sir, usually it will be glove and stocking type, sir. Large fiber neuropathy. Stocking and glove, sir.
Okay, you can continue.
One more question.
Yes, sir.
Gausi,
Yes, sir.
if the patient is having sensory ataxia, where
Yes, sir.
would you like to localize? You told of two things. What are the conditions you localize to this patient?
So the sensory ataxia will try to localize in the large fiber in the peripheral nerve, sir.
Okay. Only peripheral nerve, or if the patient is having posterior column involvement?
Sir, I can may also say like posterior column and dorsal root ganglia, sir. But for dorsal column pathway, I have to examine the patient also, sir.
Yeah. So what will you be examining the patient between, how to differentiate between the posterior column and peripheral neuropathy?
The spinal vibration, sir.
Only spinal cord vibration? Anything to deal with reflexes? Peripheral neuropathy, reflexes can be affected
Okay,
also, or
okay,
can
sir.
more than that of the posterior column.
Okay, sir.
And coming to your chief complaints, can you just put your chief complaints once again?
Yes, sir.
So in that unsteadiness while walking is there for 4 years,
Yes, sir.
and difficulty in using lower limb is for 2 years.
Yes, sir.
So what was that difficulty in using the lower limbs? Because you explained in history of presenting illness that there was no weakness in getting upstairs. So what was the difficulty actually for the patient in using the lower limbs, apart from that unsteadiness? Because unsteadiness was there for 4 years.
Yes, sir. So patient couldn't able to get up from the chair, sir. And also patient couldn't able to get up from squatting posture after using restroom, sir.
Okay. So the patient is having proximal muscle weakness of the lower limb also.
Yes,
So
sir.
you want to tell
Yes, sir.
as per the history. Okay. Go ahead. And one more thing, you told about unsteadiness while the switching off the lights, and patient wants to sit in a lighted rooms always.
Yes, sir. Yes, sir.
What does it mean?
Sir, it is sensory. The patient may have sensory ataxia, sir.
Okay. For the patients for a sensory ataxia, what
Yes,
all the system has to be intact for a patient to maintain the patient without having a sensory ataxia?
sir, visual input, sir.
Okay. Only visual input?
Vestibular components,
Yeah.
sir.
Totally
Including
3
semicircular
things are
things.
involved. Yeah. If 2 out of these 3 things are involved, the vestibular, proprioceptive, visual,
Yes,
in
sir.
a intact cerebellar system, if it is involved,
Yes, sir.
patient can go with that sensory ataxia.
Okay, sir.
Okay, just proceed with it. Okay, you can proceed, Gausi.
Okay, sir. So past history, no history of any similar complaints in the past. No history of diabetes mellitus, hypertension, hypothyroidism, seizure disorder. No history of any previous surgeries, hospital admissions, chronic drug intake. History of COVID infection in 2021 and no IP admissions or oxygen requirement. History of COVID vaccination, 2 doses thereafter.
What COVID vaccination?
Covishield, sir.
Okay, yeah.
So then birth history, patient was third born of third degree consanguineous marriage. It was normal vaginal delivery at hospital. Tried
One more
immediately.
thing, Gausi.
Yes, sir.
Cardiovascular involvement, was there anything in the past history?
The past history, sir. No, sir. No, sir.
No cardiac involvement. Okay.
No, sir.
And you also spoke about weight loss. Would you consider the weight loss a significant weight loss or insignificant weight loss?
Yes, sir. It's a significant weight loss. It was more than 5% reduction, sir. Weight, sir, in the last more than 6 to 12 months, sir.
Okay, and you said it was unintentional.
Unintentional weight loss, sir.
So what are the general categories of conditions when you have an unintentional weight loss? What are you thinking about?
Sir, it could be a chronic chronic thing, sir, or it could be malignancy.
One, we have a general differential diagnosis. Next, we have a differential diagnosis applied to this particular patient.
Okay, sir. Sir, it could be malignancy, sir.
Okay.
Sir, it could be endocrine cause like hypothyroidism, sir.
Hypothyroidism
Sir.
and weight loss.
Hyperthyroidism, sir. Yeah,
Okay,
weight loss. Hyper,
okay.
sir.
Yeah.
So then,
What else?
sir, chronic infections like immunocompromised disease like HIV.
Right.
So then even diabetes mellitus, sir.
So did you bring all that history into the history? Because you should ask about polyphagia, polydipsia, should ask about tremors. Did you ask about all those histories?
Yes, sir, I mentioned it in the history of personal illness, sir.
Okay, you have mentioned that. Okay. And what are the categories? So one, you spoke about chronic infections, you spoke about thyrotoxicosis, you spoke about diabetes, malignancies, and then anything else?
Chronic infections like TB, sir, or chronic inflammatory syndromes.
Okay, is there anything in the history to suggest any of these etiologies?
Sir, it could be malignancy, sir.
Okay, so if you were to link malignancy and this chronic process, what kind of process in your opinion, what kind of condition are you thinking about?
Paraneoplastic syndrome, sir.
Okay, so you believe there could be, since there's unintentional weight loss, there could be a paraneoplastic syndrome with cerebellar signs, right? Something like that.
Yes, sir.
Okay, so okay, yeah, continue.
So then, birth history. Patient was third born of third-degree consanguineous marriage. Was a normal vaginal delivery hospital and cried immediately after birth.
Who gave all this history?
Sir?
Who gave all this history? Normal vaginal delivery, cried immediately after birth.
A patient only said, sir. Patient and
the patient remembers her own birth.
An attender also was there, sir. Her father
Who
was there.
Who was the attender?
Father, sir.
Okay, so who gave the history, the patient or the father?
Sir, both of them, sir.
Okay.
So then, she was vaccinated appropriately as per national immunization schedule. Personal history: consumes mixed diet, normal sleep and appetite, normal bowel and bladder habits, and she's menstruating with regular cycles. Has 2 daughters, 18 years and 17 years old, living normally. It's a pedigree chart, sir. Coming to summary, a 49-year-old female born of third-degree consanguineous marriage with complaints of insidious onset, gradually progressive, symmetrically progressive ataxia of the trunk, limbs, and gait, with sensory ataxia and difficulty in using upper and lower limbs, speech disturbances, tremors with significant weight loss, without involvement of higher mental functions, cranial nerves, or autonomic nervous system involvement. So the probable structures involved: cerebellum and its connections, posterior column of spinal cord, and proximal muscle groups with significant weight loss. And the etiology I would like to point is like inherited ataxias, vitamin deficiencies, or any metabolic disorders, hypothyroidism, demyelinating disorders, chronic infections, autoimmune conditions, and paraneoplastic conditions.
So some of these conditions are to do with the neurological problem. Some of these conditions are to do with weight loss, right?
Yes, sir.
So chronic infections and ataxia, what would that be?
So chronic infection could be Lyme's disease, sir. HIV, sir.
So if you were to rearrange this order, what would come first, what would come second, and what would come third?
Sir, first I would like to point on inherited ataxia, sir. Second thing, paraneoplastic conditions, sir. Then chronic infections, sir.
No. This is the paraneoplastic conditions. Usually it's subacute, like usually presents over a period of 3 to 6 months. The usually paraneoplastic ataxia is rapidly progressive. Okay,
Okay, sir.
So if you have a female, though there is a history of significant weight loss, the progression in onset and progression is not typical of a paraneoplastic cerebellar ataxia. Okay.
Yes,
So
sir.
usually most of the paraneoplastic cerebellar ataxias will have some amount of cognitive decline also. So I think it's typically not fitting. Dinesh, am I correct?
Yes, Dr. Balkrishnan, or there could be an alternate etiology for weight loss going on, which is separate from the cerebellar ataxia.
Yeah. The thing is, paraneoplastic, though this definite weight loss is there, only thing is not the typical onset. Okay.
Did you look for depressive symptoms in this patient? Somebody with a cerebellar ataxia not able to do activities of daily living. I'm sure there must have been some depressive component, Dr. Kaushik.
Sir, patient said she's doing her regular activities and other things, sir.
No, did you use the
No.
depression screen here, this PHQ-2 screen, right?
No, sir.
Depression. Yeah, maybe because see, somebody who's been functioning very well suddenly, is not able to function, and so that could be a depressive component. Do you think the cerebellar ataxia patient might have a depressive component, Dr. Balakrishnan?
Yeah, they can have anxiety, they can have depression because of the loss of job and income, and definitely they can have.
So, so those kind of maybe you could have just screened her for those conditions, Dr. Kaushik.
Yes, sir.
So, what kind of? I think Sanjo. Yeah. Just maybe this order is okay for you, or?
Actually, can you go back to the one more slide previously, that summary? That's
Yes,
49-year-old female. So is it a early onset or late onset ataxia?
late onset, sir.
Okay, how to classify that, early or late?
25 years, sir. It's less than 25 years and more than 25 years, sir.
Okay. Symmetrical progressive ataxia of the
Yes, sir.
gait, sensor loss, difficulty in using upper and lower limb,
Yes, sir.
speech disturbance, tremors.
Yes, sir.
So with this history, which thing you have to put it in the first, actually for this patient, 4 years history, no?
Yes, sir.
So can you go to the next slide, please? Okay, out of this inherited ataxia, you want to put it in the first.
Yes, sir.
Why?
Sir, because any late onset ataxia, sir, usually it will be inherited ataxia, sir, mostly.
Okay, fine. Inherited ataxia in the sense?
Sir, it may be autosomal dominant, recessive, and X-linked, sir. You have to classify accordingly, sir. And with the autosomal dominant, spinocerebellar ataxias and episodic ataxias and
Autosomal
dentatorubropalatosomal.
recessive will come in the late onset ataxia, most commonly.
Autosomal recessive, sir?
No. I'm asking that you told it can be autosomal dominant, it can be autosomal recessive, and
Yes,
all
sir.
kind of ataxia.
Yes, sir.
Usually, autosomal recessive more common. What is the most common type of autosomal recessive ataxia?
Sir, Friedreich's ataxia.
Friedreich's ataxia. What is age
Early
of
onset,
onset actually?
Early onset, sir.
Early age of onset. So the Friedreich's ataxia only come in early age of onset, or anything can come in late onset Friedreich's ataxia?
Sir, atypical Friedreich's ataxia can occur after 25 years, sir.
Yeah, late onset are there, and one more thing is there.
Low fast, sir.
Very late onset Friedreich's ataxia is there. It is more than 40 years.
Okay, sir.
25 years late onset, 40 years very late onset is there.
Okay,
And
sir.
normal Friedreich's ataxia is there. It comes in the regular place.
Okay, sir.
Second thing is you told of vitamin deficiency. What are the vitamin deficiencies you consider for this patient?
Sir, vitamin E, sir. Vitamin B1, sir. Vitamin B12, sir.
Okay. If you consider vitamin E,
Yes.
you told of proximal muscle weakness there. What is the most common vitamin E? How will be the most common presentation for the patient?
Sir, vitamin E deficiency patient will have involvement of, because vitamin E is needed for both the posterior column and spinocerebellar tract integrity, sir.
Vitamin E deficiency?
So vitamin E deficiency will cause both distal and proximal, sir, and it will
Usually,
predominant
vitamin
of
E
GI
is
symptoms
most
also,
commonly
sir.
cerebellar and peripheral neuropathy will be common with vitamin E deficiency,
Okay, sir.
rather than pyramidal pattern of weakness.
Okay, sir.
Then metabolic disorders. Why did you
Yes, sir.
consider hypothyroidism for this patient?
Sir,
Because of the weight loss, sir. No,
No,
the
sir,
patient
because
had a weight gain, no?
Yes, sir, because of
In
the proximal
hypothyroidism,
muscle.
usually patient have weight gain, no?
Yes, sir, because of the proximal myopathy, sir, and also chronic severe hypothyroidism patient may also have cerebellar involvement and also sensory involvement, sir.
But you told of a weight loss of more than 10 kg, no?
Yes,
So
sir.
whether
Maybe
it
an added
coincides
super
with
added component on that, sir.
So, supra-added component you are adding to it.
Yes,
So,
sir.
demyelinating disorder, you are telling about demyelinating disorder. What are the demyelinating disorder you have to point to for this patient?
So multiple sclerosis, sir.
Okay, what about the eye finding? Whether you have told about any eye finding for this patient? Usual things.
Sir, if suppose if it is a demyelinating disease, I would want to see for optic atrophy, sir.
So, what are the other
Particular
things that affects the eye other than multiple sclerosis?
Sir, with the patient with ataxia, sir.
Yeah, patient with ataxia and eye involvement. What are the common things you can point to?
So usually spinocerebellar ataxia type 7 will have retinal involvement, sir. Retinal degeneration,
Yeah,
macular
okay.
pairing, sir.
Okay, fine.
And Refsum's disease, sir.
Okay.
And also Wilson's disease will have Kaiser Fischer-Ring and cataract, sir.
Okay.
And cerebrotendinous xanthomatosis will have a patient will have cataract, sir. Presenile cataract will be there. And
Okay.
also Miller-Fisher syndrome patients will have ataxia with ophthalmoparesis, sir.
Okay.
Myotonic
Can
dystrophy
Frederick's
patients may have cataract, Christmas tree cataract, sir.
can have Frederick's ataxia can have eye involvement?
Yes, sir, like optic atrophy, sir.
Okay, fine. And apart from that, next is chronic infection. As already discussed, chronic infection. What are the infections you point here? Lyme's disease only or
This Lyme's
HIV?
TB, HIV, sir.
TB, HIV. Okay,
Tabes
fine.
dorsalis also, sir. Tabes dorsalis, sir.
Tabes dorsalis for this patient. Autoimmune conditions. What are the things you have to point to?
Sir, anti-gliadin antibodies, sir.
Okay.
Syndrome, sir. Then anti-TTG, like Whipple's disease, sir. Then Sjogren's syndrome also, sir.
Okay. Okay. One more thing is when you classify for the etiological factors, always it is better if there is a patient's pedigree chart is not convincing for inherited ataxia.
Yes, sir.
So treatable cause of ataxia, you can also consider that as treatable cause of ataxia and non-treatable cause of ataxia.
Yes, sir.
And if the treatable cause is there, we can treat it fast. So
Yes, sir.
autoimmune condition, vitamin E deficiency, and all kind of things you can treat. Even
Yes,
if you put as an inherited ataxia as the first thing,
Yes,
without
sir.
a pedigree chart, it is normal only. There is no blame in that. But
Okay.
inherited ataxia, you can come to the point, but we cannot treat much
Okay, sir.
if you diagnose a scar for this patient.
Okay, sir.
Okay. Okay. Proceed.
Yes, sir. Sir, my differential diagnosis, sir, at this point of time could be spinocerebellar ataxia, vitamin E deficiency, vitamin B12 deficiency, A beta lipoproteinemia, hypothyroidism, and CV junction anomalies, foramen magnum syndrome, and paraneoplastic conditions.
Any other vitamin that can cause apart from vitamin E, vitamin B12?
B1, sir.
Okay, fine.
So then general examination, patient is conscious, oriented to time, place, and person, and she is moderately built and nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. And height is 165 centimeters, weight is 76 kgs, BMI is 27.9 kg per meter
Yeah,
square.
your comments on the BMI.
Sir,
What is
patient,
the
patient is
yeah.
obese, sir.
So what is the Indian classification and what is the Western classification?
Sir, sorry, sir.
What is the Indian classification and what is the Western classification of obesity?
Sir, WHO classification is underweight is 18 point less than 18.5 BMI, sir, and a normal weight is 18.5, 24.9, sir.
Okay.
And overweight is more than 25, sir.
Okay.
Obese is more than 30, sir.
Okay. And beyond 30?
So beyond 30, we'll classify it as like obesity class 1, class 2, class 3, sir.
Okay. What about India? Indian classification?
Sir, in India,
South Asian population? Or what is the cutoff? Is it the same as the Western?
so no, sir. If it is it's an Asian, it is more than 30, sir. It's obesity. Overweight is obesity is more than 25, and in Western it is more than 30, sir.
No. Overweight is between 23 to 24.9.
For Indian, sir. For Indian
For
guidelines.
Indian, yeah. For obesity is beyond 25 in India.
Yes,
So
sir.
based on Indian classification, should actually be considered obese.
Yes, sir.
Yeah, continue.
So then height neck ratio, it is 12.4, and patient has asymmetric hyperpigmented macules on both sides of the cheek and the
Okay, I'm
nasal
going to
tip.
ask a very basic question. What's a macule?
Sir, macule is a It's a plain area in the skin, sir, where there may be hyperpigmented or hypopigmented, sir, along the area of the skin, sir.
Is the macule elevated or not elevated?
Not elevated, sir. It's a flat, sir.
Macule should be differentiated from what? What's a papule?
So papule, it will be having a raised margin, sir.
What's a plaque?
Sir, plaque with the scaling, sir, and also it will have the size would be more than 5 millimeter, I think, sir.
No, a papule is an elevated lesion, whereas a plaque is a elevated flat lesion.
Yes, sir.
And
Plaque.
what's a pustule?
Sir, pustule is a vesicle-filled cavity, sir.
Okay, yeah, continue.
What's the importance of height neck ratio in this patient?
Sir, because of to rule out CV junction anomalies, sir.
So when will you consider that height neck ratio cutoff?
Sir, 13.6, sir. If it is more than 13.6, patient has short neck, sir.
So types of CV junction anomaly?
Sir, it may be bony and soft tissue, sir. And if it
Okay.
is bony, it may be platybaseal, then atlantoaxial dislocation
Okay,
type.
okay. Apart from that, what are the neurological causes?
Sir, it may
You
cause
have to
Arnold
know.
Chiari malformation, sir. Like
What are the types you know?
Sir, type 1, 2, 3, and 4, sir. Type 1 is patient will have cerebellar tonsil herniation, sir. Type 2
Okay.
is patient will have cerebellar tonsil, vermis, and meningomyelocele, sir. And type
Okay.
3 is patient will have defects in the inferior region of the occiput region and also C1, C2 with myelomeningocele, sir. With the
Okay.
hindbrain with the small posterior fossa. And 4 is with the hyperplasia of the cerebellum, sir.
Okay. You told of no neurocutaneous markers. What are the neurocutaneous markers you will look for?
Sir, couple spots, then neurofibromas, then
Okay.
chagrin patches, sir. Then
Okay.
port vein stain, sir. Port
What
stains.
is Ashcliffe macules?
Sir, Ashleaf macules are hyperpigmented macules, sir.
Okay.
Hypomelanotic macules, sir.
Okay. Where will you find that?
In tuberous sclerosis patients, sir.
Okay. What will be the mental status of a tuberous sclerosis patient?
Mental retardation will be there, sir.
Mental retardation will be there. Okay. And where will you get a slabbed cheek appearance?
Sir, in parvovirus infections, slap cheek.
Okay, fine. Okay, proceed.
Yes, sir. So then no peripheral nerve thickening, skeletal abnormalities, and hair loss.
Okay, where will you check for peripheral nerve thickening?
Sir, for leprosy, sir, for CADP patients, sir, then for amyloidosis, sir, then for acromegaly, sir.
Where are the position you will check in a patient?
Sir, in the hand, maybe in the ulnar nerve, sir, and
Okay.
in the greater auricular nerve in the face, sir. Then supraorbital nerve,
Okay.
sir.
Okay. That's all. Lower limb.
Plantar nerve, sir, natal plantar nerve, sural nerve,
Okay, fine. Sural.
sural nerve. So then no history of any peripheral nerve thickening, skeletal abnormalities or hair loss. Vitals, pulse 90 per minute, regular in rhythm, normal in volume and character, no radioradial, radiofemoral delay, all peripheral pulses felt equally, no vessel wall thickening, BP 100 by 70 mm mercury measured in right arm in supine position, no orthostatic hypotension noted, respiratory rate 12 per minute, thoracoabdominal type, and SpO2 99% in room air, and temperature 98.4 degree Fahrenheit measured in the right axilla. CNS examination, sir. With higher mental functions, patient is conscious, oriented to time, place, and person, and the immediate, recent, and remote memory intact, and speech and language, scanning type of dysarthria present, and mini-mental status examination score 29 by 30, and mood and affect, it's normal.
Now, can
And,
you describe the components of the mini-mental state examination?
yes, sir. Patient will have we are checking for orientation of place, sir, and time, sir, and
Yeah.
and also we are checking for registration, recall, and we are asking to do attention and calculation by subtracting 100 minus 7 like by 5 times, sir, and also we are checking the language in the form of naming two objects and repetition, sir, like no and and should not be used. Then
Yes.
three stage comments and we should ask the
Yes.
patient to write a sentence with meaning and copying two intersecting pentagons, sir.
Right. And what condition does it help to find out?
Sir, it is for assessing the cognition, sir, for assessing dementia, sir.
Okay. Yeah, continue.
What is the shortcoming of MMSC actually?
Sir, shortcoming.
What is the shortcoming?
If the patient is illiterate, patient can't able to do so.
You cannot do. So what are the cutoff in the patient who is having a primary school, high school, college, graduate level? So what are the cutoffs you use?
Don't know, sir. Sorry, sir.
18 for illiterate, 24 for primary, 27 for higher primary, and 27 for graduate actually, 29 for graduate.
With the scores, we can calculate that way. Okay, sir.
Yeah. No. These are the mandatory things that patient should have. If the patient is a graduate, he should have that thing. If it is below that, the patient's minimal state examination is abnormal for the patient. You have
Okay,
to
sir.
consider for that education for the patient actually.
Okay, sir.
Okay.
So then mood and affect normal, no emotional liability present. So cranial nerve history, sir. Cranial nerve, first
How
cranial.
do you say mood? How do you say mood and affect normal?
Sir?
Mood and affect normal, no?
Yes, sir. Sir, the patient is depression. That may be patient may be like mood can be hyper and also hypo, sir. Like maybe depression or mania in conditions it may affect, sir. It may affect the mood, sir.
Okay. Continue.
And one more thing, if MMSC for illiterate, do you know any mental status examination for an illiterate patient?
Yes, sir. It's a Montreal cognitive assessment, sir.
Hindi mental state examination, one more thing is Hindi mental.
Okay.
Do you know what is MOCA?
Sir, MOCA is Montreal cognitive assessment
That
scale.
is not for illiterate actually. It is for literate actually only because
Okay,
it is somewhat Hindi mental state examination is for illiterate.
Okay, sir. Okay, sir.
Okay.
Yes. So then cranial nerve, sir. Cranial nerve 1, patient is able to perceive smell on both sides, sir. Then optic nerve, visual acuity, Snellenstadt with the Snellenstadt right and left it's 6/6, and visual field, color vision and fundus examination normal, sir. Then 3, 4, 6 nerves, no ptosis, no squint, and the extraocular movements full, pupil size 3 millimeters, and direct and indirect light reflex present on both sides, accommodation reflex present, and the gaze evoked nystagmus present on both sides, sir. So then fifth cranial nerve, sir. Sensory part, ophthalmic, maxillary and mandibular divisions, it was intact, sir. Then motor component, temporalis, masseter, pterygoids, function all were intact, sir. Then reflexes, corneal conjunctival reflexes were intact, sir. And jaw jerk, it was normally present, sir. So then seventh nerve, sir. Motor, wrinkling of the forehead, closing of the eyes, and was normal both sides, sir. Then nasolabial fold present, and patient is able to hold air in the cheeks, sir. Then angle of mouth is normal, and sensory part, taste present in the antetooth of the tongue, and sensation of the tragus normal, sir. Then moistness of the eyes and tongue normal. Yes, sir.
So basic question, reflex root values for Jojak.
Sir,
Jojak afferent and different. Okay.
Sir, it is both fifth nerve, sir.
Fifth nerve. And center?
Center is mesencephalic nucleus, sir.
Okay, fine. What about corneal conjunctival? You'll be knowing.
Yes, sir. Corneal is fifth nerve, sir. Afferent is seventh nerve, sir.
Okay, fine. Can you proceed?
Yes, sir. So then cranial nerve 8, sir. Rennie's test, bone conduction more than air conduction, and Weber's test, no lateralization present, sir. Then 9th and 10th nerve, uvula and midline, gag reflex present, and palatal movements normal and equal on both sides, sir. Then 11th and 12th nerve, trapezius and sternocleidomastoid muscle, it was power was full, sir. Then patient able to do movements like turning head to head, and tongue bulk and tone was normal. Power and tongue protrusion was able to do normally, sir. No deviation of tongue noted, sir.
How will you test for the 9th cranial nerve in gag reflex?
Sir, for 9th cranial nerve, we should ask the patient to, we should touch with the stick, sir, in the both sides of the palate, sir, in left and right palate, and also in the posterior regions. The afferent will be by the 9th nerve, sir.
Okay, so how will you test whether it is the afferent is wrong or afferent has gone?
Sir, we should ask the patient to say ah, sir. If there is elevation of the, if there is elevation, there's efferent is intact, sir.
Okay. So
And if on
10th is
touching, there is
intact.
no contraction, the ninth nerve is affected, sir.
Touching, no, unilateral 9th means?
Sir, you unit ninth now, if we are touching on the right side, there won't be elevation of the right side, sir. But there will be contraction of the other side, sir.
Okay. And one more thing is you can ask the patient whether you are able to feel the sensation also.
Sir, sorry, sir. Oh, okay, sir. Okay, sir.
You can also ask the patient whether you are able to feel also, and you can compare it, the contraction on the both sides, whether you have touched the left side. If
Okay,
there is
sir.
a contraction on the both sides, means the 9th is intact actually, 10th is working actually normal.
Okay,
And
sir.
the patient is able to sense that sensation also, it will be fine.
Okay,
And
sir.
saying the patient, the 10th is normal.
Yes,
That
sir.
can also can able to differentiate between 9th and 10th.
Okay, sir. Shall I proceed, sir?
Yeah, yeah, yeah.
Yes. So then bulk and tone, sir. Sir, bulk in the right and left, it is almost equally the same, sir. And tone in the right upper limb and the lower limb, there is hypotonia, sir. Hypotonia present, sir. So then power, sir. In shoulder.
Okay. Define tone.
Yes, sir. Sir, tone is the partial state of contraction of the muscle at rest, sir. Which
Okay.
is,
And what are the different types of tone?
sir, patient may be having hypertonia and hypotonia, sir.
Okay. In hypertonia, what are the types?
Hyper, sir.
Hyper, yeah.
Sir, it may be spasticity, rigidity, sir.
Okay.
And one more thing.
Sir,
And one more thing, spasticity, rigidity. Okay,
paratonia,
rigidity type.
paratonia
Okay.
Gegenharten, sir.
Okay. And one more thing of paratonia, only Gegenharten.
There is Midgehen, sir.
Okay.
Okay. And how do you what is the difference between spasticity and rigidity? It's a very basic question.
Okay, sir. So spasticity, it is velocity dependent, sir. Rigidity is it's not it's velocity independent, sir. And spasticity is present in pyramidal tract lesions, sir. Rigidity is present in extrapyramidal system lesions, sir. And here there will be spasticity, there will be hypertonia, and the patient will be having clasp knife type of spasticity, sir. And rigidity, there may be lead pipe or cogwheel, sir. Cogwheel in the wrist and lead pipe in the elbow. We should check it for, sir.
Okay. And what is paratonic rigidity?
Paratonic rigidity, sir. Sir, usually it is found in the frontal lobe dysfunctions or any psychotic diseases, sir.
What happens there?
So there will be, when we give resistance, sir, the patient will move in, the patient will give resistance in the opposite.
Exactly.
Opposite
They'll
side.
resist the
Yes, sir.
examiners. The movement of the examiner is resisted by the patient.
Yes, sir.
Okay.
What is
And
cogwheel rigidity?
Sorry, sir.
Cogwheel rigidity.
Sir, cogwheel rigidity, it is present in the Parkinson patients, sir. It will usually we'll check in the wrist, sir.
So what is the cause of that cogwheeling?
Cogwheeling, sir. Sir, cogwheeling is lead pipe rigidity, which is superimposed with tremors, sir.
Okay. Okay, pa.
Yes, sir. Sir, power, sir. Upper limbs, shoulder, abduction, adduction, flexion, extension, internal rotation, external rotation is 5/5.
now one more thing. What about hypotonia? What are the causes of hypotonia?
Sir, hypotonia, it could be due to LMN involvement, sir, or it could be due to.
Okay, can you just trace the low motor neuron?
Yes, sir. Sir, it is from the anterior horn cell, sir. Then posterior root, sir. Then dorsal root. So then neuromuscular junction, sir. Then it is nerve, sir. Then it is nerve, neuromuscular junction, muscle, sir.
Can
Okay.
you tell me in
Now,
that order, please?
Sir, anterior horn cell, then motor roots, sir. Then plexus, then nerves, then neuromuscular junctions and muscles, sir.
no, there is
Okay.
an anterior root and a posterior root.
Yes, sir.
See, there are two roots,
Yes, sir.
and then so you can either have a spinal cord. The low motor neuron can be at the spinal cord of the anterior cell,
Yes, sir.
or it can be a root, in which case it's a radiculopathy,
Yes, sir.
or it can be in the plexus, which is a plexopathy, or it can be the peripheral nerve, which is a peripheral neuropathy, neuromuscular junction, or the muscle,
Yes, sir.
as well as the sensory component as well.
Yes, sir.
So as we told of anterior root and posterior root,
Yes, sir.
for a brachial plexus, which root you have to tell about, anterior or posterior root? which forms the brachial plexus actually.
Sir,
From the spinal cord, one root comes as anterior, one root goes as posterior.
yes, sir.
So both will join together to form brachial plexus, or only one thing?
Ventral only, sir.
Yeah, okay, fine. What will go with that posterior? Posterior, what the posterior root will
Sir,
do?
will supply the back, sir.
Okay, paraspinal muscles. Okay. So if the patient is having some anterior horn cell lesion,
Yes, sir.
some EMG finding of the paraspinal muscles can be done, so that you can also diagnose with an anterior horn cell disease
Okay, sir.
because of that posterior root.
Okay, sir.
So the cause of hypotonia can be, what are the structures involved in hypotonia?
Sir, hypotonia, that may be anterior horn cells, sir, or it
Right.
may be element lesions and cerebellar diseases, sir. And hypothyroidism also can cause, sir. Or any upper motor neuron lesion with shock, sir.
No, it's not like that. So yeah, upper motor neuronal shock. So in the motor component, it can be anterior horn cell. In the sensory component, so is it, you spoke about peripheral low motor neuron, right?
Yes, sir.
One, it can be at the level of spinal cord side, the motor side, which is the anterior horn cell.
Okay,
What
sir.
about the sensory side? Give me an example of a sensory cause for the hypotonia.
Okay, sir.
Like a Tabes dorsalis or herpes zoster can also cause a hypotonia.
Okay, sir.
Can you have combined motor and sensory for hypotonia?
Sir, subacute combined degeneration, sir.
No, for hypotonia, like a cord or a root compression can also cause a hypotonia.
Okay, sir.
You can have a root compression where you can have a motor and a sensory component. And then you spoke about cerebellum, right? Cerebellum.
Yes, sir. Cerebellum, sir.
Any involuntary movement?
Yes, sir. Patient may have intentional tremors, sir.
No, any involuntary movement in the basal ganglia which can cause hypotonia.
Chorea, sir.
Chorea, right? Okay. Yeah, you can continue.
So then power, sir. In the shoulder, abduction, adduction, flexion, extension, internal rotation, external rotation is 5 by 5, sir. And the elbow flexion extension is 5 by 5, sir. Then wrist joint flexion extension is 5 by 5. Hand grip is 100% both sides, sir. Then hip flexion extension, adduction, abduction, internal rotation, external rotation is 5 by 5, sir. Then knee flexion extension, it's 5 by 5. Ankle dorsiflexion, plantar flexion is 5 by 5. The neck flexion extension is 5 by 5, sir. So then superficial reflexes, sir. Corneal, conjunctival.
So there's no muscle power weakness.
No, sir.
Okay.
If there was a pyramidal pattern of weakness, what do you mean by pyramidal pattern of weakness?
Sir, pyramidal tract will be like if the lesion is in the spinal cord, that may be ipsilateral hemiplegia.
No. I'm asking about pyramidal pattern of any other. You told of abduction, adduction, flexion, extension. No. So
Yes,
in
sir.
any, if corticospinal tract is affected,
Yes,
so
sir.
what will be the pattern of involvement in the upper limb and lower limb?
Sir, flexors will be involved in the upper limb, sir, and extensors will be involved. Anti-gravity muscles will be involved, sir.
No. I'm asking about weakness.
So distal weakness, sir, more than proximal weakness, sir.
That you can tell, but the thing is, pyramidal pattern of weakness is abduction in the upper limb, abduction of the shoulder,
Abduction with the shoulder joint, sir. Then flexion of the elbow and flexion of the wrist joint, sir.
Yeah, and lower limb.
So lower limb, there will be extension of the hips, sir, with the flexion of the knee, and there will be plantar flexion of the foot, sir.
Weakness of the flexion of the hip, flexion of the knee, and the dorsiflexion of the ankle.
Okay, sir.
You told about the weakness patient attitude. I think you will be telling
Yes, sir.
about the patient's attitude.
Yes, sir.
But I'm asking about the weakness of the muscles or weakness of that movement.
Okay, sir.
So
Okay, sir.
shoulder abduction, elbow extension, and wrist extension in the upper limb, and the lower limb is a flexion aspects only.
Okay, sir. Okay, sir.
I have another question in reference to muscle weakness. What is the differential diagnosis of muscle weakness?
Sir, muscle weakness, it could be due to central cause or peripheral cause, sir. So
No, yeah, right, yeah.
Sir, in peripheral cause, it could be due to muscle disorders, or it could be due to neuromuscular junction disorders, sir, or it could be due to peripheral nerve lesions involving sensory motor components, sir, or it could be due to the anterior horn cell lesions, sir.
No. I think the broad classification is upper motor neuron versus lower motor neuron and myopathy. So it's upper motor neuron, lower
Yes, sir.
motor neuron, myopathic, myasthenic.
Yes,
So how
sir.
do you differentiate between the different types of muscle weakness?
Sir, muscle weakness, sir, if there
What
is
was common to all the four? Okay, it's obviously loss of power. The muscle weakness means loss of power will be common to all the four. So beyond that, between upper motor neuron, low motor neuron, myopathy and myasthenic, what is the differentiating features?
Sir, for myasthenic, there will be diurnal variation will be there, sir. And if it is myopathic disorder, if it is myopathies, predominantly it will be proximal involvement, sir. And
No, what I
symmetric.
mean is you have to talk in terms of tone, reflexes, plantar, fasciculations, and power.
Okay, sir. In UMN, LMN, and myopathic and
Yeah.
Okay, sir. Sir, in UMN lesion, sir, there will be power will be there will be hypertonia, sir, but there will be muscle power will be low, sir, but muscle wasting will be there due to disuse atrophy, sir, and plantar will be extensor, sir, and reflexes will be exaggerated, sir.
Okay, in element?
Sir, in element the element there will be hypotonia, sir, with the flyerness of the limbs, sir, and there will be absent reflexes, and there will be plantar will be absent, sir, mute, sir.
Okay, and you can have fasciculations.
Okay, sir.
In myopathic weakness?
Sir, myopathic weakness, it will be pertain to the only muscle, sir. Which
Only-
muscle corresponding muscle one will be affected, sir, and wasting will be there.
Yeah, so plantar, tone, reflexes.
Sir, if that muscle is involved, that component of the reflex will be affected. It will be variable, sir.
Right. So and myasthenic?
Sir, myasthenia.
Yeah.
Sir, myasthenia usually it will be involving the istosis and also there will be proximal muscle weakness of the upper limbs with the respiratory muscle involvement of the upper limbs, sir. So usually dependent reflexes will be preserved, sir.
Yeah, so repetitive muscle contraction they may not be able to sustain contraction.
Yes,
And
sir.
generally the weakness will get exacerbated at the end of the day because of fatigue.
Yes, sir.
Okay. What is myotonia?
Sir, myotonia is there will be persistent contraction even after upon stimulation. There will be persistent contraction, sir. There will be failure of relaxation, delayed relaxation.
Yeah, right. Impaired relaxation. Okay. Yeah. Continue.
So then superficial reflexes, sir. Superficial reflexes like corneal, conjunctival, abdominal reflexes, anal reflex all present, sir. Then plantar, flexor on both sides, sir. So then deep tendon reflexes, sir. It's biceps, triceps were 2+, and brachiosaurus were 2+, sir. And knee reflex was 1+, sir. And,
Okay, what are the other ways of eliciting the plantar response?
Sir, plantar reflex, sir, if the plantar is absent, we can go for Chaddock reflex, sir, or open hymns, or Schaffer's reflex, sir, Gordon, sir.
Where do you stimulate in Chaddock?
Sir, in Chaddock, we will be stimulating the lateral malleolus, sir. We should start
Okay,
from the middle lateral malleolus.
Okay, Gordon's reflex.
Sir, Gordon's usually we squeeze the gastrocnemius muscles, the calf muscles.
Okay, open him.
Sir, open him, we should drag the knuckles in the shin region, sir.
Okay, what about how do you elicit deep tendon reflexes in the fingers? I mean,
Sir,
reflexes in
Wattenberg
the
sign
fingers.
and Hoffman sign, sir.
How do you do it?
Sir, in Wattenberg sign, we should ask the patient to interlock the examiner's hand, sir. And usually there will be extension of the thumb, sir. If there is adduction and flexion of the thumb, it is abnormal, sir.
Okay, Hoffman reflex.
Sir, Hoffman's reflexes, the examiner should hold the distal differential joint. Examiner should stabilize it, and that there should be given a flickering kind of movements in the tip of the
Which finger? Which finger?
middle finger, sir.
Middle finger. Okay.
Then what is Wattenberg sign?
Sir, Wattenberg sign, sir.
Yeah. Can you get any Wattenberg sign in neurology?
Sir.
If there is an ulnar neuropathy, the little fingers will be abducted in position, cannot adduct because of that muscle weakness. So that sign is known as Wattenberg sign. And this is Wattenberg reflex, Hoffman's.
Okay, sir.
And what is minimal plantar response?
Sir, minimal plantar responses, there will be only the tensor facial alone will be contracted, sir.
Okay, you told about Oppenheimer.
Yes, sir.
Reflex, B-I-N-G.
Sorry, sir?
Bing reflex, B-I-N-G.
Sir, wings reflex, we should, with the pin, we should prick the dorsum, sir. Dorsum.
Okay, that is also a reflex for?
This is a plantar equivalent, sir.
Okay, okay. Any other equivalent you know?
Sir, Moni's reflex, sir.
Okay, fine, fine. Lot are there. 20, 30 are there. So okay, you give it.
Okay, sir. So then knee jerk is just 1 plus, sir. Then ankle jerk, it is absent, sir. So then sensations.
What is the explanation for absent ankle jerk in a 14-year-old female with all these findings?
Sir, usually ankle jerk, it will be ankle flex will be diminished, sir. It will be 1 plus only, sir. Usually in the normal people. So if it is absent, we can think of any disease of the afferent arc or in the spinal cord lesion involving the reflexogenic area in the S1 region, sir. Or
So what is your theory? What structure do you think is involved in her?
sir, either peripheral neuropathy, peripheral nerves can be involved, sir, or else there could be S1 radiculopathy, sir.
Okay, is she a vegetarian?
No, sir, patient
You
is
said
mixed diet,
mixed
sir.
diet. You said mixed
Mixed diet,
diet.
sir.
Okay, yeah, continue.
So then sensations, sensory system, sir. Crude pain, touch and temperature normal, sir. Then fine touch, proprioception, position sense was normal. Then cortical sensations like 2-point discrimination, tactile localization, then stereognosis, graphesthesia, then sensory inattention, and bilateral simultaneous stimulation, all were intact, sir. So then cerebellar signs, gaze evoked
Okay,
nystagmus.
before that, regarding sensory system,
Yes,
what
sir.
are the different types of sensory receptors you're aware of?
Sir, Pacinian corpuscle, sir. Then
Okay.
Ruffini's end organ, sir. Then
Right.
meisner's corpuscles.
Okay, meisner's is responsible for what?
Meisner's corpuscle, sir. For
Yeah.
pressure, sir.
For touch.
Touch, okay, sir.
Touch. Pacini for
Pin, sir, for the pain sensation, sir.
vibration. Merkel disc is for pain. Ruffini is for warm and skin stretch, and end bulb of cross is for cold.
Okay, sir.
Now, I also have one more question. What is the specificity theory in response to neurology?
Sir, each
What do you
drug
mean
will
by
carry the specific sensation alone, sir.
right? So, what are the 4 types of sensory receptors?
4 types of sensory receptors. Sorry, exteroceptive receptors.
Now, pertaining to what 4 sensations?
Sir, mechanoreceptors, photoreceptors.
No, it's heat, cold, touch, and pain.
Okay, sir.
Does the specificity theory hold good at all times?
Okay, sir.
Now, I'm asking you, does it hold good at all times? Does it generally mean that each receptor will respond only to one sensation?
No, sir, it's not like that, sir.
Yeah, but the threshold for one particular sensation will be lower than the other sensations, but they can respond to multiple stimuli.
Yes, sir.
And one more thing is, what are the different types of nerves? Like in the sense, how do you classify nerves?
So nerves, it could be myelinated, unmyelinated, sir. And
Okay.
we can classify as motor nerve, sensory nerves, sir.
Right.
And also with an autonomic fibers also, sir.
Right. Now, what is the you have a Erlanger-Gasser classification of nerves, right? You have a classification of nerve fibers.
Yes, sir.
How do you classify that?
So it's classified as 1A, 1 alpha, 1 alpha, beta, sir. Then
No, it's A alpha.
yes, sir. A alpha, beta, then delta, sir, and gamma, then type 2 and 3, sir.
It's B and C. So, which type is responsible for cutaneous pain?
Sir, cutaneous pain, it is C, sir.
C fiber. Okay. Which nerve fibers are in muscle spindles and motor to skeletal muscles?
Sir, it's 1 gamma, sir.
So motor to skeletal muscle is A alpha.
Alpha, sir.
Yeah, sympathetic preganglionic.
Sympathetic ganglion is 2, sir.
Yeah, it's B or 2. Yeah. And what does A delta? What does A delta do?
Sir, A delta for nociceptors, sir, and also cold receptors, sir.
Yeah, it's temperature and pain. Right. Okay, continue.
So then coming to cerebellar signs, sir. Gaze evoked nystagmus was present in both eyes, sir. And truncal ataxia was present. and bilateral finger nose test positive, and rebound phenomena is present, sir, and the bilateral dysdiacokinesia was positive. Then bilateral heel shin test was patient not able to do, sir. Then drawing a circle, patient is not able to do. Foot tap test was positive. Tandem walking was impaired, sir. And gait, weight-based ataxic gait. Then scanning speech was present. And pendular knee jerk was absent, sir. And titubation absent. So then Rombergs could not
A
able
wide
to do.
gait.
Yes, sir.
When will you tell a wide-based gait?
Sir, if the distance between the two things, sir, if the distance between the two foot is more than 12 centimeters, sir, or if the each person's foot length will vary, sir. So more than the length of the one's foot in between the two foot, sir.
Okay. Whether the patient had any pendular knee jerk? You
No,
told
sir.
absent.
No, sir. No, sir.
So, what is pendular knee jerk?
Sir, pendular knee jerk is the hypertonic thing, sir, in the lower limb. So if it is more
Okay.
than 5, it is significant, sir.
More than 5, it has to be more than 5. In some books, says more than 3 itself is significant.
Okay, sir.
Okay. Okay, you told us scanning speech. What do you mean by scanning speech?
Sir, there will be undue separation of the syllables in each word, sir.
Okay. Any other type of speech because of cerebellar involvement?
Yes, so there may be staccato speech, sir, which is an explosive kind of speech with the explosive kind of speech, sir. With
Okay,
stress on each
without,
syllable. Sir?
if the patient is having a cerebellar involvement, if
Yes,
there
sir.
is no scanning and if there is no staccato, can there be a cerebellar lesion? Can you suspect a patient who is having just dysarthria
Yes,
and there is no scanning, no staccato, still the patient can have cerebellar or not?
sir, but patient is having dysarthria, sir.
Yes.
Sir, maybe.
Because I'm telling that scanning and staccato need not be scanning and staccato always.
Yes,
Some
sir.
kind of
Sir,
dysarthria
maybe,
instance can.
sir, maybe spastic speech also can be there if the truncal portion, if the pontine lesion, if the middle cerebral peduncle involvement is there, there may be ataxic gait with ataxic spastic speech, sir.
Okay, but need not be scanning and staccato always, even though it is classical for cerebellum.
Okay,
Even
sir.
dysarthria can be present there. Normal kind of dysarthria can also present in cerebellar also.
Okay, sir.
It is wide kind of dysarthria is described in cerebellar kind of speech. Scanning and staccato is a classical teaching. It can present in cerebellar lesion.
Okay, sir.
Okay. Okay, carry on.
Now, how do you assess balance in a normal person?
Sir, balance we can check with the for upper, there is both upper limb and for lower limb balance, sir. In upper limb we can check for finger nose test and finger nose finger test, sir.
No. What is the 4-stage balance test?
Sir, sorry, sir.
4-stage balance test. Okay, there's a test where for testing balance, especially in Parkinsonism or other conditions where there's a lot of disequilibrium or
Okay.
imbalance. So basically, you ask the patient to stand with the feet slightly apart, eyes open. Then they stand in what's called the big toe touching the back end of the other foot.
Okay, sir.
Right, and then they stand in a tandem stand, just like you have tandem walking, you have tandem stance.
Okay,
That
sir.
is one foot in front of the other foot, heel touching the toes touching the heel of the other foot. Most
Okay.
people will start swaying here. Finally, they stand with one leg, one foot, and then they have to maintain balance. First, you try with the right foot and then with the left foot. If they can
Okay.
maintain balance, then it's fine. If they don't maintain balance, then they have to practice balancing exercises.
Okay,
This
sir.
this is across ages, but more commonly in elderly people.
Yes, sir.
Okay, continue.
So then Romberg, sir, Romberg could not able to do because there was more swaying, sir, and no extrapyramidal signs were present, sir, and no signs of any meningeal irritation, and the spine and cranium was normal, and no corrected Drury or thrill, and no peripheral nerve thickening, foot drop or wrist drop, sir, and autonomic nervous system examination, sir, no postural hypertension, and no sweating or no resting tachycardia, sir.
Define orthostatic hypotension.
Sir, it is defined as systolic BP more than drop in systolic BP more than 20 and diastolic BP more than 10, sir. From at the gap of 3 minutes from supine to standing, and also heart rate variation should be more than 30, sir.
Patients be more than
Sir,
heart rate, difference in heart rate will increase
30,
by how
sir.
much?
30, sir.
Are you sure?
Yes, sir, 30, sir.
I think it's 10.
Okay, sir.
Why does orthostatic hypotension happen?
Sorry, sir?
Why does it happen normally? What are the causes?
So orthostatic hypotension could be due to primary and secondary, sir. Primary, it could be
Right.
due to primary autonomic failures like alpha synucleinopathy, sir. Uh, like uh, uh, multiple system atrophy or any Parkinson, sir. And also secondary
Okay.
causes could be due to diabetes, amyloidosis, and the chronic conditions, sir.
Right. And what happens when somebody, usually when somebody gets up from the lying to the standing posture, what happens?
From lying to standing, sir.
Yeah, from lying to standing or sitting to standing, what happens? Why doesn't the BP drop in a normal individual?
So because of the intact sympathetic autonomic nervous system, sir.
Right. So, so what happens? How does the autonomic? What are the reflexes which maintain the blood pressure when you stand up?
Sir, baroreceptor reflex, sir.
Yeah, you have cardiovascular writing reflexes, which happen instantaneously. And what happens in Parkinsonism and elderly people?
So there will be involvement of the autonomic nervous system in the form of synucleinopathy, sir. So there will be primary autonomic failure. Autonomic system failure will be there due to
So there'll be a
baroreceptor dysfunction.
yeah,
Baroreceptor
there'll be
dysfunction.
right. There'll be a failure of these writing reflexes.
Okay, sir.
Yeah, you're right. The heart rate more than 30 or more, right? So orthostatic hypotension. So orthostatic hypotension, you check when you check the blood pressure.
Sir, from supine to standing after an interval of 3 minutes, sir.
Okay. Yeah, continue.
So then other system examination, sir. Cardiovascular system S1, S2 plus intact.
Just
Present.
another quick question. What are the types of orthostatic hypotension in terms of timing?
Timing, sir.
Yeah.
I'm not sure, sir.
You can have early orthostatic hypotension, you can have orthostatic hypotension, you can have delayed orthostatic. It's 1, 3, and 5 minutes. You can have
Okay.
early, the regular orthostatic hypotension and delayed orthostatic hypotension.
Okay, sir.
Okay, continue.
Then, sir, cardiovascular system, sir. S1, S2 present, sir. Then RS, respiratory system, normal vesicular breath sounds, and no added sounds, sir. Then per abdomen, it is soft, non-tender, no organomegaly present, sir. Sir, coming to diagnosis, sir. 49-year-old female, born out of third-degree consanguineous marriage, with complaints of insidious onset, gradually progressive, symmetrically progressive ataxia of the trunk, limb, and gait, with positive cerebellar signs, hyporeflexia, hypotonia, and significant weight loss, without involvement of the higher mental function, cranial nerves, sensory system, or autonomic nervous system involvement. So the structures involved, pancerebellum with its connections, and the differentials, sir, at this point of time, late onset spinocerebellar ataxia, vitamin E deficiency, A beta lipoproteinemia, and paraneoplastic conditions, sir. So then investigation, I would like to do complete blood count, renal function test, liver function test, sir, and thyroid function test, vitamin E, B1, B12 levels, then ECG and 2D echo, MRI brain with whole spine, then nerve conduction studies, sir, then whole genomic sequencing. So this is the MRI picture of this patient, sir, with the it's a T2 weighted imaging with the cerebellar atrophy, sir. That's it, sir.
No, I think you're not shown the genetic testing report.
Sir, genetic report for testing, it was actually it was
SCA
negative.
panel is negative and whole exome sequencing is also negative. Yeah.
Yes, sir, it's negative. It was negative, sir.
So, what are the most common type of cerebral ataxia in India?
India, it is type 2, sir.
What is the name of the ataxia? Who first described in the world? I think it's Wadia. Okay.
So, sorry, sir?
Wadia.
Wadia.
Wadia. Wadia. Okay.
Okay, sir.
So what are the very characteristic feature of a type 2, maybe SCA type 2?
So type 2, there may be slow saccades will be present, sir. And also there will be patient will be having akinetto-rigid syndrome, sir.
Akin rigid. Type 2.
Akinetto-rigid, sir. The rigidity will be akinetto-rigid, sir.
No. What are the meaning? Akinetic rigid or?
No. The thing is, it is a type 3. Out of that, you are telling of A1, 2, and 3 again subdivision. Or
No,
whether
no,
SCAR 2 you are telling.
SCAR 2, sir.
SCAR 2
2.
can even have peripheral neuropathy, pyramidal features, lot of things can be present with the SCAR 2 also.
But not Parkinson. Okay.
Yes, sir.
So this patient has a definitely purely cerebellum plus some amount of peripheral neuropathy.
Yes, sir.
Okay. So does she fit into any classical subtypes of SCA? Like autosomal dominant cerebellar ataxia?
Sir, if peripheral neuropathy is involved, either we can say Macaro-Joseph type 3, sir, or SCAR 4, sir.
SCAR 1, there is no peripheral neuropathy.
Sir, SCAR 1, there will be pyramidal signs with spasticity alone, sir.
Still, peripheral neuropathy is also present in SCAR 1. Because
Okay,
if you take that SCAR, the full thing, the peripheral neuropathy is present in a lot of things, but it is not pure peripheral neuropathy.
okay, sir.
But pyramidal SCAR 1, 2, and 3 can also present with the peripheral neuropathy findings also.
Okay, sir.
Can coexist with that.
Okay, sir.
What's the most common in worldwide?
3, sir.
3. Okay. Any SCAR in any American presidents?
Lincoln, sir. Lincoln ataxia, sir. Type 5, sir.
Type 5. So what is the most common trinucleotide repeats in SCAR?
Sir, it may CAG repeat, sir.
So where you can get CTG repeats?
In type 8, sir.
Retinal you already told.
7, sir.
So pentanucleotide repeats?
10, sir.
What is that pentanucleotide?
Sir, it's ATTCT, sir.
Okay, fine.
So in a patient with cerebellar autosomal dominant cerebellar ataxia,
Sir?
so in any patient with ataxia,
Yes,
okay,
sir.
inherited ataxia, so what are the areas of the brain or the spinal cord always you look for evidence of some damage?
Okay, sir.
So where are the areas you just look for maybe evidence of maybe some maybe like atrophy?
Sir, in cerebellum, there will be atrophy, sir. In
Okay,
SCAR.
cerebellum, okay, cerebellum
Sir,
we
and
know.
also
Where
in
else?
spinal cord atrophy, there can be present in Friedreich ataxia, sir.
Which part of the spinal cord?
Cervical spine, sir.
Okay, and so what will happen to the cerebellum in Friedreich's ataxia?
So it will be usually, it will be normal, sir, in Friedreich
It'll
ataxia.
be- So where else you look for in ataxia? What is OPCA?
Sir, I can't get you, sir.
What is OPCA?
Sir, OPC is olivopontocerebellar atrophy, sir.
So where do you expect atrophy?
Sir, cerebellum, sir. SCAR 1, sir.
No, pons also.
Okay, sir.
You can so you have to always look at the pons, you have to look at the cerebellum, and always you look at the spinal cord. Okay. So in any form of maybe if you don't know the etiology, I think always just do the spine also. But if you have a typical Friedreich's ataxia, you will have a cerebellum will be normal, but you will see a spinal cord atrophy. Okay.
Okay, sir.
But can you get a
So
cerebellar atrophy in Friedreich's ataxia?
So usually, classically, it won't be there, sir.
Classically, it won't be late stage. You may get in the
Okay, sir.
Friedreich's ataxia and very late onset. If there's a typical Friedreich's ataxia features are there, in that you may get a cerebellar atrophy also can be get. But classical things you will not get in Friedreich's ataxia.
Yes, sir.
There will be only cervical atrophy.
Okay, sir.
So how do you maybe look for cerebellar atrophy? How do you maybe identify the cerebellar ataxia in MRI?
Cerebellar ataxia in?
No, in MRI. When you say there is a cerebellar atrophy.
Yes, sir. Sir, there will be decrease in volume of the posterior fossa, sir. And there will be either Posterior fossa, that the T2 intensity will be more, sir. The CSF volume will be more. Parenchyma will be less, sir.
In the axial scan, okay.
Yes, sir.
Okay. So in axial cuts, how do you look for cerebral atrophy? So you have to see a okay. Just you have to see more than 10 foliae, okay,
Okay, sir.
in the axial cuts.
More than 10 foliae,
Okay.
sir.
More than 10 foliae, more than 10 fissures, like
Okay,
foliae.
sir.
Okay.
Okay, sir.
So then you know that very well. There is a patient definitely has a cerebral atrophy. Okay.
Okay, sir.
So which condition has more anterior lobe atrophy than other part of the brain? It's alcohol. Okay.
Where's which type, sir? Sorry, sir.
Alcohol.
Alcohol. Okay, sir.
Alcohol has more of anterior part of the cerebellum will be atrophied, and they are mainly gait ataxia. Okay.
Okay,
Though the
sir.
cerebellum is involved in alcoholic cerebral ataxia.
Okay, sir.
So what are the other drugs I think can cause cerebral ataxia? Long and there is used for long term.
Sir, drugs it can be phenytoin, sir, and also
What are the most common drugs? What? Yeah.
lithium, sir. Alcohol, lithium, sir.
Yeah. Phenytoin.
Sir,
No. Phenytoin.
phenytoin.
Phenytoin. So which
Okay, sir.
cells is the phenytoin is toxic in cerebellum?
Sir, it can cause even acute cerebral ataxia and also chronic cerebral ataxia.
No. I'm just asking. Patient is on long-term phenytoin use, on long-term phenytoin, and patient after 15 years are coming with cerebral ataxia. So which is the cell which is damaged in the cerebellum, whether it will be reversible or not? Hello?
Dentate nucleus, sir.
No. It is more damage to Purkinje cells of cerebellum. Okay.
Okay, sir.
The Purkinje cells of the cerebellum will be damaged, and most of the time it is irreversible. Okay.
Okay, sir.
So sometimes it's very difficult to reverse. Okay.
Okay, sir.
So they'll have severe cerebral ataxia. Okay.
Okay, sir.
Sanjo, anything?
Nothing, sir.
No. Whether this
You
patient, I think we can put as a autosomal dominant, that is late onset cerebral ataxia.
Okay,
yes,
sir.
sir.
Does this patient has any scoliosis?
No, sir. No scoliosis, sir.
Any diabetes?
No, sir.
Any hard of hearing?
No, hard of hearing actually, patient doesn't say any symptoms, sir, but bone conduction was more than air conduction, sir.
So any pescavers or high arched foot?
No, sir. No, sir. No hammer toes, no pescavus, and no scoliosis, hyposcoliosis.
Okay. So whether the as Sanjay told, whether this patient can fit into late onset maybe Friedreich's ataxia?
Sir, but there is no sensory symptoms on examination, sir.
Okay.
actually there is a criteria for Frederick's ataxia. You know the
Harding's
name of the
criteria, sir.
criteria? Okay. So what all the things that you come in Harding's criteria, you know about that? Five
Sir,
things.
Sir, if it is age less than onset less than 25 years, sir.
Okay.
Sir, and also patient should have both. There should be kyphoscoliosis, sir, and also there will be,
Scoliosis need not be there, no?
sir, then progressive
Scanning or speech
ataxia,
skin.
sir. Progressive
Okay.
ataxia.
Yeah.
Sir, then absent ankle and knee jerk, sir. Ear flexing.
Okay, fine. And that scanning speech, no. Dysarthria.
Okay, sir.
That has to be present within 5 years of onset of the disease. That also has to be present.
Okay, sir.
So, but this Harding's criteria can be violated by late onset Frederick's ataxia also,
Okay, sir.
because it's less than 25, no? So more than 25 also means more than 25 late onset. Very late onset is also can be present,
Okay, sir.
but it is rare. The common things are common always.
Okay, sir.
So this is not fitting into late onset Friedreich's ataxia. So can genetic testing maybe normal in maybe a patient with autosomal dominant cerebral ataxias?
Sir?
Can SCA panel, see this patient has undergone only SCA panel and
Whole genome sequencing, sir.
whole exome sequencing. So this sometimes can miss the trinucleotide expansion disorders. Okay.
Okay, sir.
So our Indian panel has limited maybe only 5-6 SCAs only they check. Okay.
Okay, sir.
So I think if we check in detail, I think we'll be able to identify the type of the cerebral ataxia. So there is any treatment for this patient?
Sir, treatment, first we should give correctable causes like vitamin E, sir, And
Okay.
and correctable causes hypothyroidism. If it could be the cause, we can correct
No,
it.
no, I'm just asking this patient.
Sir, as of no proven role for any medications in SCA, sir. But idipinone has been tried as some monoclonal antibody, sir. It has been tried, sir. It has a better role in Friedreich's ataxia, and it improves the myocardial fibrosis, sir. And even riluzole is also tried, sir, as a free radical scavenger, sir.
Okay, this patient has not improved with any treatment.
Sir, this patient saying like the symptoms are static, sir. But patient is able to do her normal work with the symptoms, sir. She's managing to do her work, sir.
Okay. So what is your final impression regarding this patient? Maybe you can just give a single diagnosis for this patient.
Sir, late onset spinocerebellar ataxia, sir.
Okay. So subtypes you don't know.
Yes, sir.
Subtypes is very difficult. Yeah.
Yes, sir.
Okay. Anyway, it's good
So if you
presentation.
have the activity of daily living, now the patient is this thing
Sorry, sir.
and can do all these things also, it will be enough. Means it will be fine. Activity of daily living, dependency also can be said in history of presenting illness. Initially, patient could do like this, and after
Okay.
this much years, she couldn't do like this. Activity of daily living also has to be mentioned in history of presenting illness.
Okay, sir.
Dinesh?
Yeah, I'm fine. Just one question. What's the reason for the weight loss?
Sir, weight loss, we should find for the maybe appetite, maybe less, or we should find the causes for any malignancy by doing whole body PET CT kind of thing, sir.
Maybe, yeah, we might have to screen for underlying health conditions.
Or
And
maybe
you
any
can,
super added depressive disorder also, sir.
okay, fine. I mean, yeah, we should screen for underlying beyond the neurological complaint. Either it could be depression linked with this particular complaint, or a separate condition which could be causing it.
Yes, sir.
Okay. So can we wind it up, Dr. Balkrishnan? And any other?
Yeah, no problem. I think we can mind it up. I think, but anybody has, actually they can ask any doubts like the participants, they can message us or like that.
There are
No.
only 7
Live stream
participants.
only. It's only live stream. May not be having any messages, but
Oh, okay.
because the panelists to just give a input to the presenter
Okay.
regarding the exam-oriented presentation. Anything else he has to improve? Final tips to him.
No. Actually, the few things I think initially the history is brought up with like sensory ataxia also and the proximal muscle weakness in the history. But finally, when they examine, finally there is no muscle weakness. Okay.
Yes, sir.
Okay.
No. The thing is actually history-wise, as he is told, there is difficulty in getting up from the squatting posture.
Yes, sir.
That indicates that this is definitely a proximal muscle weakness, but in the final examination, there is no definite proximal myopathy.
Yes, sir.
In the history-wise, in the examination. Okay.
Yes, sir.
And the chief complaints, I think there has to be some modification of the terms used.
Okay, sir.
So difficulty in using maybe ataxia or maybe weakness, but I think when you are presenting ataxia, the more like everything fitting into like ataxic history will be a good choice of words in the chief complaints.
Sir, clumsiness in using upper limbs.
Yeah. That's that maybe the better words in this chief complaints. Okay.
Okay, sir.
So come to the next slide. I think so. This is a few suggestions. I think there is some discordance between the history and the clinical examination. Most
Yes,
of the
sir.
time, examiners will like to hear maybe whatever you're told in the presenting complaints on the history, just maybe confirmed in the examination, or maybe sometimes even excluded. But here I think I just told them to involve like toxins. I think the history and all you are told, yeah, long-term drug use and other things
Yes, sir.
you are
Yes, sir.
told.
Yes, sir.
Okay, so just rephrase some words and that will be good.
Okay,
All
sir.
right,
Yeah.
Sanju?
Dinesh and Sanju.
Yeah, sometimes what happens, the history depends on the patient's own words, and we tend to literally write it down. But then when you're examining, you realize that the patient could have meant something else. So
Yeah,
the
yeah.
question is whether you need to go back and alter the history, or do we keep it like that?
Actually, it is always told to go back and alter, sir. But the thing is, during examination purpose, I don't think that there won't be enough time for us to alter much.
Yes, and another thing is, even when you're when you're phrasing the history, you must demonstrate that you're actively differentiating between a cerebellar, vestibular, and sensory ataxia. So you kind of show that you have multiple differentiating diagnoses in mind,
Yes,
and
sir.
that you're comparing and contrasting these conditions, and you must demonstrate that in history taking.
Okay, sir.
That's
From the
what I
exam
just
point
wanted
of
to
view, the Discord and what the panelists are discussing about, the suggestion would be, because the exam is going to be MD level only 1 hour, not more than that. But we can start having a small paper while examining the patient, interacting with the patient, scribbling out the important information. When you find at the time of the examination, maybe I would say like at the end of the 30 minutes or so, but you should have finished everything. In that case, what you can do is try to avoid whatever the patient's symptoms and the examination bit of more discordant. You try to edit that instead of
Okay, sir.
making the statement of writing the case sheets completely from the beginning.
Okay,
Is
sir.
making some scribbling, and from the time of maybe 25 minutes or 30 minutes, you start writing your case sheet. You try to edit that so
Okay,
that
sir.
what Sanju was telling you about, it's very difficult to go back. Yes, it's acceptable, but when you're going to make interaction with the patient, history taking examination, start scribbling important points.
Okay, sir.
And the exam point of view at the MD level, they're expecting you to write the complete sentences, not with the hints. So it's very important. At the same time, it's time consuming. So try to train yourself for writing more case sheets. That makes your job more easy to do the examination concern, the writing the case sheet in a timely manner.
Okay,
Okay.
sir.
And another thing, sorry, you continue.
Yeah, and the time of presentation, always make complete investigations also. I think you're not presented only the MRI part, you're presented. Probably the next presenter onwards, try to project all the investigations. So that at MD level, they might discuss investigations, including imaging and the non-imaging also. So
Okay, sir.
next presenter, I'm expecting the presentation of complete investigations, so that it's easy for the examiners also to discuss in detail about specific aspect of the investigation related to the case per se. Okay, this is Dr. Dinesh. Please.
Dr. Kaushik, as Dr. Sanan said, you'll have to put up the results of the tests. Like CBC means you have to put up the results. TSH means you have to put up the results. You have to put the the investigation findings.
Yes, sir.
So what it involves is you'll have a quick run while you do the history and examination. There'll be certain aspects of the history. Once you examine, you may want to go back into the history and add some more. You may want to confirm some other findings. So it may not, maybe a single history exam, you may have to do 2-3 times back and forth. And then you may have to write the case sheet. And then you may have to mentally rehearse it in your mind 2-3 times before you start presenting.
Yes, sir.
And you should possibly try to anticipate the questions you could get. You should try to recollect the answers. So it would be a real quick process where you may have to rehearse a few times and try to recollect some possible questions which can come.
Okay, sir.
Okay,
And,
anyway, good, man.
Yeah, it's a
Yeah,
good
Sanjay,
presentation.
please.
Sanjay, please. Sanju.
Yes, sir.
No, you were
Anything
telling
inputs
something?
to you present?
Yeah, the thing is actually nice, and what all the presentation is very good at all. But the thing is, you have to more cautious about that. What all the questions you are getting and answer appropriately, and what all the diagnosis, provisional diagnosis, and final diagnosis you have to comment on.
Okay, sir.
Yeah, I think presentation's quality is concerned has improved a lot. From my assessment last 3 years or so, has improved a lot this presentation. I think he has to keep up the momentum of the good presentation. You are supposed to listen to the examiner's question, then try to answer.
Okay, sir.
Don't prejudice yourself with the question what is going to be asked by the examiner. Don't jump with the answers.
Okay, sir.
Number 2, some definitions are asked. You're trying to answer the first cause, then you're trying to define.
Okay, sir.
Okay, so that's not the way to answer. Supposed to answer whatever the question is asked to you.
Okay, sir.
Because Sanjay was asking about some tremors related to tremors. I think, because not tremors, cogwheel rigidity. You said still in Parkinson's, then trying to explain what is cogwheel rigidity.
Okay, sir.
He is not explaining. Examiner is not expecting you to tell the cause.
Okay, sir.
You try to define what is what. They asked by the examiner. Then
Okay,
wait
sir.
for the exam. He'll be asking you another question, which is going to be cause.
Yes, sir.
Then you're going to finish 2 questions which you are aware about. Okay.
Okay, sir. I'll correct
So
it, sir.
don't offer the answer, second answer unnecessarily,
Okay,
by
sir.
which we are going to avoid a easy question for you.
Okay, sir. I'll correct it, sir.
Yeah, you try to answer the question first, then try to answer the other parts.
Okay, sir.
Just try to refine your presentation, is always going to be good, and keep up the momentum. Yeah.
Okay. Thanks.
So other examines, the panelist is not having any questions. Can we call up this day?
Yeah, we can
Okay, sir.
discuss.
Yeah, really. Thank you, Dr. Balashnan and Sanju and Dr. Dinesh for wonderful discussion. And I appreciate that Kaushik Ram for wonderful presentation on this. Probably we'll meet the next week with the next topic on this presentation of postgraduate. Thank you and good night to all of you. Thank you.
Thank you, sir.
Thank you. Thanks.
Thank you. Good night.